I'm happy to be your host for tonight, Russ Jaffe. I'm an internist physician and biochemist, a certified clinical nutritionist, and a fellow of the National Academy for Clinical Biochemistry. I'm an overseas fellow of the Royal Society of Medicine, and I maintain a fellow status in the American Society for Clinical Pathology, the American College of Nutrition, the American College of Allergy, Asthma, and Immunology, and the American Medical Laboratory Immunologist. I'm a fellow of the Health Studies Collegium and director and founder of both PERQUE and ELISAIACT Biotechnologies. Well, let's jump right in and look at this interesting, very common, all too common today, problem of chronic fatigue, or CFIDS, and fibromyalgia. And what you find is remarkable similarity of their symptoms. And I'm particularly folks who have recurrent flu-like feelings, which are really free radical activation indicating antioxidant deficits. That can be a harbinger of chronic fatigue syndrome and fibromyalgia, but really a sign of deconditioning in the body's defense and repair system. Lack of restorative sleep is common in both conditions, as it is for all deconditioning syndromes. A sense of malaise and foreboding that diminishes your optimism and your ability to see the world as a friendly place. Memory impairments that are otherwise unexplainable. Similarly, headaches and pains that are otherwise unexplainable. Vision changes, GI symptoms. These are remarkably common among the folks diagnosed with chronic fatigue syndrome and the folks diagnosed with fibromyalgia. Indeed, people with chronic fatigue syndrome often have tender points in their muscles that are fibromyalgia-like, if not actually qualifying for fibromyalgia as a diagnosis. And similarly, people with confirmed fibromyalgia often have many, if not all, of the characteristics of chronic fatigue syndrome. Here you see it visually represented, the complex myriad. On the right side, you see a picture of the sculpture, The Three Graces by Antonio Canova. That's in the Louvre. And you see some yellow dots, which are the specific points of tenderness that are assessed for the diagnosis of fibromyalgia to be made in its classic form. And you see on the left side of the slide the overlap of what we would, from the center, look at as prolonged fatigue states, and the overlap with, to the right, fibromyalgia, and beneath that, irritable bowel syndrome, and coming around anxiety and depression and formal chronic fatigue syndrome itself. So we see remarkable overlaps. A lot of it has to do with the diagnostic focus and preference of the diagnostician. So the same patient in different clinical hands might be primarily diagnosed as having CFIDS, or in another clinic fibromyalgia, or in another clinic depression, or another clinic irritable bowel syndrome, or in another clinic sleep disorders or panic attacks. And yet, when we look at the individuals who are involved, there's remarkable overlap and similarity amongst all of these, and the differential in terms of diagnosis is often has more to do with the clinic than with the patient. What about CFS, or CFIDS, the chronic fatigue syndrome, and FM? What are some facts about CFIDS and fibromyalgia? Well, first, CFIDS affects between 100 and 250,000 people in the United States. Not a small number of folks are suffering from chronic fatigue syndrome. The diagnosis is 3 times more common in women than men. It's about 2% of the U.S. population, and about 90% of the cases are in the mid-productive years of life, 25 to 50 age range. Fibromyalgia and osteoarthritis are among the most common musculoskeletal conditions. These are from Centers for Disease Control, CDC data, among others. And the question is, what is the difference in the syndromes? What is the difference between what we might call CFIDS, chronic fatigue syndrome, debilitating fatigue, versus fibromyalgia, musculoskeletal pain that won't respond to pain medications? In both cases, we see commonality of cause and slight different emphasis of expression of symptoms, but yet when we look more deeply, surprising commonality. Now let's look at the incidence and prevalence by age of properly diagnosed folks with FM, fibromyalgia, CFIDS or CFS, chronic fatigue syndrome, RSD, reflex sympathetic dystrophy, MDS, mitochondrial dysfunction syndrome, and we're going to look at this in women by age group, starting with young adults, 18 to 29, increasing by decade, 30 to 39, and all the way across to octogenarians. And we have different colors, lines and points representing the conditions. This is from the work of Wolf in his well-documented article in Arthritis and Rheumatism back in 1995. So the prevalence may be higher today. Clinical suggestions are that it is. But if we look at the different conditions, let's start first with our legend. On the left, we see yellow for FM. So let's follow the yellow line. We find that there's a rather brisk increase from 2% at age 30 to 39 to 6% at age 50 to 59, peaking in the 60 to 69 or 70 to 79 age group. If we look at chronic fatigue syndrome, that is the magenta color. Very similar age distribution of CFS, chronic fatigue syndrome, compared to fibromyalgia. Let's look at RSD, reflex sympathetic dystrophy. Very similar pattern, a steeper increase in productive years, but very similar patterning. MDS, the mitochondrial dysfunction syndrome, the red X's and lines, lower prevalence, not as well understood syndrome, maybe underdiagnosed, maybe just less common. And RSD, the reflex sympathetic dystrophy, signified by the light blue lines and triangles. And if you put them all together, you see at least in terms of the age at which the syndromes peak, you see some similarities. Let's look at another characteristic. Here we're going to look at a series of symptoms. Much of this comes from Buchwald and Garrity's article, some of it from Hushman's work on reflex sympathetic dystrophy. And here we've put together the RSD patients. You see them first in the light blue, then the mitochondrial dysfunctions patients in the royal blue, then the fibromyalgia patients in the purple, and the CFIDS in the light gray blue. And you see that in regard to fatigue for more than 6 months, very similar prevalences when you talk to RSD patients or MDS patients or FM patients or CFS patients. And with regard to unexplained fevers or FUOs, fevers of unexplained origin, a little more common in RSD, but again, similar prevalences in all 4 conditions. Unexplained sore throats and recurrent sore throats, unexplained headaches, arthralgias and joint pains. Notice that there's less in RSD patients for unknown reasons. Myalgias, muscle pains, common with a slight prevalence in fibromyalgia where the diagnosis is based on untreatable and unremitting muscle pain. Sleep disturbances, again, more commonly diagnosed in RSD patients, but still highly prevalent in all conditions, and meet the CDC CFS criteria. Well, 80% of the RSD patients and 30% of the mitochondrial dysfunction patients and 70% of the fibromyalgia patients, and of course 100% of the chronic fatigue patients meet the CDC criteria for chronic fatigue syndrome. What I would take away from this is that at the symptomatic clinical level, there's a lot of overlap of these mystery syndromes, and maybe we would be well served to look more deeply at these issues. Here you see the same data, just arrayed in percentages rather than in bar graphs. Buchwald and Garrity's data and the overlay of Hushman's data, we've pulled it together, and you see this remarkable similarity where we have comparable information that the symptoms of these disparate diagnoses are remarkably similar. We can look at this as a Venn diagram, as you see here, and if you want to update the data, as we've tried to do with regard to FM or fibromyalgia, There are perhaps a mean of 16 million people in the United States with fibromyalgia, a range of 2 to 25 million. CFS, chronic fatigue syndrome, 12 million with a range of 4 to 40 million. On the bottom, you see on the bottom right, RSD, 5 million with a range of 2 to 12 million, and mitochondrial dysfunction syndrome, 5 million with a range of 2 to 30 million. And you see that there's overlap recognized among these conditions. Now, these afflict 20 plus or minus 10 million people, given the overlap in 1997. This has increased probably to 25 plus or minus 12 million in the year 2000. And the clinical information that we're hearing suggests even further progression today. That the prevalence is 2 to 4 times the incidence, not uncommon in chronic diseases, but still says that while we're diagnosing many, there are many out there with the same suffering who haven't been diagnosed. These conditions are increasing 3 to 10% a year. That's a substantial rate of increase, and they account for a minimum of $200 billion in incremental and excess costs of disease care each year. If we look at the etiology of fibromyalgia with and without chronic fatigue syndrome, reflex sympathetic dystrophy, and mitochondrial dysfunction syndrome, we see combined host hospitalities expressing throughout the body. So if we're a psychosomatically oriented physician, we see a loss of host hospitality and competence. If we're a virologist or an immunologist, we see dysfunctions there. If we're an endocrinologist or a neurologist or a geneticist, we see defects within our area of interest. And I suggest that when we look at the whole person, we're looking at combined host hospitalities, and that's where the real issues are, where the real opportunities are, and where our physiology first, the alkaline way approach, will prove helpful. Well, let's look at the usual clinical care approach to pain in patients with fibromyalgia or chronic fatigue syndrome or reflex sympathetic dystrophy or mitochondrial dysfunction syndrome. An emphasis on education about stress and not letting the imbalances of life overwhelm us, cultivating daily habits, participating in mutual support groups, including behavior modification so that we do cultivate restorative sleep and healthy sleep rhythms. We recommend to folks the use of dichromatic green lights and salt and soda baths using Epsom salts and baking soda with a little bit of sesame oil in a warm tub of water so that they can relax into the time when they should slip into deep and restful and restorative sleep. Equanimitas is a word. It's also the name of a book by Sir William Osler of essays that I highly recommend. And reading something that is spiritually enriching briefly before bed is recommended. Learning to schedule and pace ourselves so that we're doing our most productive parts of the workday when we are most productive, even if that means an unusual schedule for a period of time. We recommend low-impact aerobics. We do recommend stretching exercises such as Milton Traeger Mentastics. You might want to watch the videos of Roger Toll and others on the internet and benefit from the Traeger system, Pilates, Alexander technique, Feldenkrais system. These approaches to systematic and joyful, pleasant stretching and low-impact aerobics often help recondition folks who've been deconditioned in ways that are enabling, that are building of learned optimism, and that deliver better clinical outcomes at lower costs. The next category is medications. We do not generally recommend these, but there have been the use of amitriptyline and other cyclobenzaprine type of antidepressants. There have been the use of NSAIDs and serotonin reuptake inhibitors, SSRIs, and even some of the more recent third and fourth generation serotonin and or DOPA regulators. They've had some spotty successes and in individual cases may be useful, but in general they have found to be not very helpful. They don't really suppress the symptoms effectively, and they certainly don't address the causes. So let's look at how we can take care of these folks using the pathology approach in comparison and contrast to the physiology first approach. On the left, you see the morbidity dysfunction pathology approach. On the right, you see the homeostasis tolerance physiology first approach. On the left, you do tests that are designed to measure the last 20% of remaining function. And your goal is to get the diagnosis correct, to name the condition and the syndrome accurately. And the best that we can look at is statistical information, information about morbidity and mortality, information about how the individual compares to some statistical group for laboratory procedures or for diagnostic references. That's the case-based morbidity dysfunction pathology approach, and we suggest a different one. On the right, you see care based on homeostasis and tolerance, the physiology first approach. The tests are done to measure qualitative functions or abilities. How much functional ability do we have, and how can we enhance that? The goal is to achieve a functional outcome, a superior clinical outcome, and the best we can look at are patient-specific individual information that we can learn to live companionably with ourselves and with others based on appreciating our strengths and recognizing our needs or our deficits and managing them proactively so that proactive prevention is our primary approach. The physiology first useful lab tests include assessment tools that we'll talk about, diagnostic tests, therapeutic targets, and treatment guidelines. Here on the right, you see a figure borrowed from the Smithsonian archives. On the right, you see the immune system, including lymph nodes and the lymphatic channels. In the middle, you see the neurochemical system, the nervous system, including the nerves running along the dermatomes. And on the left of the figure, you see the hormonal system and the major endocrine organs in the body. In fact, the three come together as one governing system, as it's referred to in Chinese medicine, and are three aspects of one control system in human physiology. Now, with regard to translating lab tests into outcome and clinically useful information, we want to use tests that are assessment tools that lead to diagnostic and differentiating tests and therapeutic targets and treatment guidelines. And the information should be that the assessment tools give us a screen of functionality. We know how well and how much better a person might be functioning. We move on to a functional confirmation, a more specific, a more sensitive, a more predictive test or set of tests, and then we use these to monitor outcome results wherever possible, having the individual measure something about themselves so that we have complete outcomes. We resolve the cause, we reverse the deficit, we address the need, and then we don't have the symptoms because the cause of the problem has truly been modulated. The cause of the problem has been recognized and worked with, and as a consequence, the symptoms go away. We don't need so much in the way of symptom suppressive care. We can look at the kind of quality care that is individualized and functional, and that is intrinsic to the physiology first approach. So we have functional health measures. There are 5 control systems, and they have different aspects. On the left, you see the more classic way of understanding these. This is the neurochemistry or the nervous system, the immunologic or the immune defense and repair system, the endocrine or the hormonal system, the metabolic or the acid-alkaline parts of the system, and the digestive, the ability to break down, to assimilate, to utilize and eliminate effectively. Now, when we talk about neurochemical, we're talking about mood and mental clarity. When we talk about immunologic, we're talking about defense and repair, as well as our response to distress, and that carries over in both directions to the neurochemistry and to the hormones, the endocrine. Our resilient reserves are assessment of our metabolism, and our assimilation, utilization, elimination is a measure of our digestive competence. So this physiology first approach has many things to recommend it. The most important is better outcomes, less suffering, less cost. An example of improved tests for immune status assessment are the LRA by ELISAIACT tests that I had the privilege of developing. LRA meaning lymphocyte response assay. This is an ex vivo test. This is a test that measures in the laboratory immune defense and repair systems over all delayed pathways just as they occur in the body. It is the most comprehensive and functional breakthrough in lymphocyte response assay testing. In other cases, we recommend inexpensive at-home self-tests like the first morning urine pH test, a score-based calibration to find out how much antioxidant need and oxidative stress the individual has, a hydration assessment to make sure the individual is taking in enough free water to wash through their body and their kidneys, and transit time to make sure that they're digesting food in a healthy 12 to 18 hours, not too fast and not too slow. Then there's targeted nutrient supplementation with replication or repeat of laboratory procedures to see if improvement has been made. And the Alkaline way for health restoration techniques is a very pragmatic one. It goes by results, and based on the going on now 50 to 60,000 cases we have in our database, we're encouraged that these approaches are the medicine of tomorrow that's available today. Let's talk for a moment about the lymphocyte response assay by ELISAIACT. It's done by observing functioning lymphocytes in autologous or patient-owned culture challenged with specific antigens. Here you see Shusen and I, technician and I, looking together at one specimen. You can see by the color of both of our hair that this was from the early days of the laboratory. And we measure lymphocyte responses because they're involved with all delayed allergy pathways. The lymphocytes are the final common pathway for all delayed or late phase reactions, and they're modulated by hormones, neurochemical, metabolites, acid-alkaline status, and digestive competence, all modulating or influencing how the lymphocytes, the memory-carrying white blood cells, operate. On the right part of this slide, you see a reactive slide. In a negative or non-reactive slide, you would see none of those halos around the cells. Community-based fibromyalgia study has been done using this physiology-first approach. We identified for each individual and substituted to the best of their ability for the immunoreactive substances, the ones identified by LRA by ELISAIACT tests. We corrected nutritional deficiencies that can reduce defense and repair abilities. We improved detoxification competence for xenotoxins or environmental pollutants for each individual. And all of this was done because we wanted to concentrate on enhancing human healing responses. We wanted to evoke human healing responses by systematically identifying what might be burdening the immune defense and repair system, what deficiencies might be preventing the neurohormonal system or metabolic processes from working properly, what environmental toxins needed to be removed from the body, in essence enhancing getting the good stuff in and the bad stuff out, so that we could restore the ability of the body to heal itself. Let's look at the results from the community-based fibromyalgia study. This was published in the Journal of Musculoskeletal Pain, along with my colleague Patricia Doister. And we have three groups here. We have controls, they're shown in magenta. We have primary fibromyalgia, shown in turquoise. And we have secondary or complex fibromyalgia with other chronic conditions, shown in orange. Before, or at the start of the study, the pain scores were all normalized to 100 so we could compare the populations over the next 3 to 6 months. The midpoint is 3 months. The post period is 6 months after starting the program. And by normalizing to 100% the pain scores for each of the three groups, we could then see changes. The controls went up over time, doubling their average pain scores. And you see the primary fibromyalgia group had a almost 50% reduction in pain score at 3 months that continued to decline to about 40% after 6 months. The more complex cases, the secondary fibromyalgia, shown in orange, you see a reduction in pain score, but not as much, and a further reduction over time, indicating that indeed they are much more complex cases. In regard to looking in the way we're more familiar, this is 1 over the pain score. This is the same data, just shown in a different visual form, so that the controls go down and the primary and secondary go up, in the sense that down is now worse and up is now better. Same data, just the inverse for ease of understanding. What about lack of energy? Again, we normalized everyone to the same 100% before. At 3 months, all 3 groups showed improvement. There was less lack of energy. But notice that on the right, at 6 months in the post period, there's now more lack of energy by 20%, 120% lack of energy in the control group, whereas the primary fibromyalgia have less lack of energy, more improvement in their energy at 6 months. And the same is true for the secondary fibromyalgia, but less further along. In terms of depression, all 3 groups show progress at the midpoint, but at the end or post the study, there was more depression in the control group. There was further less depression in the primary fibromyalgia, and the secondary fibromyalgia group continued to show reactive depression. Overall health, same normalization before the study. At 3 months, you see improvement in all 3 groups, but notice at 6 months, the controls have now slipped back in terms of their overall health score, whereas the primary and the secondary fibromyalgia groups have improved. Notice that the improvement is proportionately more in the secondary or complex fibromyalgia because they started from a lower baseline. So on multiple different measures in this community-based study, we showed successful outcomes in this approach. Physiology first, the alkaline way, truly integrative care. So we can practice physiology first principles, applying it to this range of fibromyalgia and chronic fatigue syndrome cases. We can restore homeostasis. We can restore the ability to restore ourselves. Homeostasis means self-re-regulation. If I'm pushed to the left, I come back to the right. If I'm pushed backwards, I come forwards. If I'm pushed forwards or pulled forwards, I come backwards. It's the body's tendency to bring itself back into self-regulation. And now with functional and predictive tests and healthy values, HV standing for healthy values, we can guide you to use measures that restore and enhance homeostatic mechanisms. Self-restoring, self-healing mechanisms. We can enhance tolerance, resilience, and elective protectives in the body. It turns out when our body is healthy, we do produce elective protective molecules. Our immune system is tolerant, not reactive and allergic. It is resilient. It is able to identify abnormal cells and remove them from the body each day. And it does produce elective protective molecules. Our body produces elective protective metallothioneins to protect us from toxic metals, and secretory IgA to protect us from foreign antigens, and mucins to trap things that need to be further digested at the mucosal surface. So by choices of consumption, by choices of activity, by choices of attitude, by choices of environment, we can, through our choices, our relationships, our interdependence with all life, we can influence 91 or 92% of our health. We can influence the supermajority by the habits and choices of consumption, activity, attitude, environment, our relationships, and our interdependence with all life. Now, we bring all this together so that people can be protected, we can recycle, and have the immune system defend us and repair us. We've summarized this in The Joy of Food, the Alkaline Way Guide. This is available in both electronic online form and physical print form. It shows the interdependent value of cultivating certain health habits and how easy it is to cultivate one small habit change at a time, to balance out rest and active stretching, to include active breathing in our stress pattern management of our day, to be more mindful, to have a time for active meditation and the practices of mental as well as physical activities, to move in ways that are resilient and constantly changing, using the mentastics of Traeger or the Pilates system or the Feldenkrais methodology, functional integration, or the Alexander technique. It is about moving joyfully through the full limits and range of our abilities. It is not so much about how fast and how far we can move. It is about how well and how resiliently we can function. If we look at our innate immune system, that is the fixed part of our immune system, the first responder part that's supposed to protect us, supposed to recycle toxins, supposed to defend and repair us, it does have an impact. Our health habits do have an impact. So do what you love and choose to love what you do. Eat whole foods, as much locally produced as possible. Eat in the alkaline way, according to the joy of food the alkaline way. Take targeted supplementations based on predictive tests and healthy goal values for those tests, consuming as much supplements as you as an individual need to meet your biochemical requirements. To increase environmental awareness through edible landscaping and permaculture and the use of our immediate environment to be a source of both visual and gustatory delight.